Good morning and welcome to Medicine Grand Rounds. We have a number of people out still checking in. We've had computer problems, so I apologize for that. But I don't want to hold up our speaker and moving forward with this outstanding topic. Dr. Roger Kulstad was born in Santo Domingo and actually attended classes first in mechanical engineering and then received his doctorate in medicine from an Instituto Tecnológico de Santo Domingo. Prior to some practice there in the Dominican Republic, he was recruited as a resident to the Marshfield Clinic, where he also was chosen to be chief resident. We were fortunate to have him come train with us in endocrinology, where he also received some coursework in global health here at the University of Wisconsin. Following that, he went on to be an associate consultant and then a consultant in endocrinology at the Marshfield Clinic, where he established the only center in the region to offer molecular profiling of indeterminate thyroid nodules. He held a position as assistant clinical adjunct professor prior to our being very fortunate to recruit Dr. Kulstad in 2016 to our faculty as an associate professor. He's published in the area of his expertise, that being in thyroid disease, with 16 publications, and he's received some grant support for that work. He's also an avid educator for medical students, fellows, and CME, and he developed a conference with our endocrinology division back in 2008 for grand rounds and live interactive video conferencing, which goes on today. He's a member of a number of the major societies in his area: the Endocrine Society, the American Association of Clinical Endocrinologists, the American Thyroid Association, as well as relationship with pediatrics as well, since he is double boarded in medicine and peds, having done a med-peds residency. He's been involved in clinical practice committees, first in several at the Marshfield Clinic and more recently at the Ambulatory Patient Experience subgroup here, working with that very important topic here at UW Health. He's also been an excellent world citizen, serving as a supervisor for medical students both in the Dominican Republic and in Guatemala, and he's received awards for the excellence of his clinical care at Marshfield, the National Committee for Quality Assurance, and by Press Ganey. We were very fortunate to have him come and really lead under the guidance of the division head for endocrinology, Vince Crines, the program in thyroid and specifically thyroid needle biopsy and aspiration. So we're fortunate to have really a leader in the field provide grand rounds for us, entitled "The Needle in the Haystack: Which Thyroid Nodules Need to be Watched More Carefully." Please join me in welcoming Dr. Kulstad.
Thank you, Dr. Page, for a very kind introduction. It is a really big honor for me to present to you today. I am overjoyed to be here. And before I start, I wanted to share a little story. When I first started fellowship training here, one of the rheumatology fellows gave a presentation on how to get started in fellowship, how to transition, and more than anything, how to talk to an attending asking you a question when you probably know a little less than you're attending. During that presentation, she put a little picture of a bumper sticker that she saw once, which said, "Remember who you wanted to be." And that kind of stuck with me. And that rheumatologist is right there. It's Dr. Bartels. That kind of stuck with me. I went and practiced at the Marshfield Clinic, and I really enjoyed my time there. And I felt very privileged to have achieved some good things there. But there was always this nagging feeling that I wanted to be involved in teaching, and I wanted to be back at the university. And so I want to thank Dr. Bartels for putting that little bumper sticker up, because I kept thinking about that for many years, and that's why I came back. I want to talk to you today about a topic that's very important to me, which is thyroid nodules. I've built most of my career around the evaluation of thyroid nodules. I have some standard disclosures. I don't have any conflict of interest, and I don't intend to discuss any off-label use of products or medications. I'll be presenting some patient images in this presentation. These are not my actual patients, but they were obtained from the greenpeace.org website. I use these images mainly to make a point, and these images are in the public domain. My objectives for today, I'd like to describe the possible driving factors behind the growing incidence of thyroid cancer in the United States and in Wisconsin. I'd like to demonstrate the steps for the evaluation of a patient with a thyroid nodule, and discuss the current strategies for the follow-up of patients with thyroid nodules. So why do we care about thyroid nodules? Why do we evaluate these? Obviously, they could potentially be important to our patients. Otherwise, we wouldn't really worry about them. And the reason we do that is because we are concerned that there could be cancer in these nodules. We've done fairly well in the battle against cancer over the past several decades. The overall incidence and the overall mortality from cancer has been going down, and that's largely in part due to you. You have counseled our patients to quit smoking, and you have made sure that our patients get screening colonoscopies and have pre-malignant lesions removed, and patients are getting their mammograms. So you are responsible for this decreased incidence and decreased mortality. But for some reason, thyroid cancer doesn't seem to be following this pattern. We have seen a rapid increase in the number of cases of thyroid cancer over the past several decades, probably faster than any other cancer around. And the question is why? This is the million-dollar question. Why are we seeing more patients with thyroid cancer? So in 2014, there was a study published by Louise Davies. She's an otolaryngologist over at Dartmouth. And what she did is she looked at the SEER database and analyzed the incidence of thyroid cancer and compared it to mortality rates from thyroid cancer. And what her data showed, or what her paper showed, was that we do indeed have an increase in the incidence of thyroid cancer, but we're not seeing a whole lot more death. And so that raised questions about whether this is an epidemic of diagnosis or whether this is an epidemic of true disease. And there was a follow-up study just published last year in the New England Journal where they analyzed this data a little bit differently. Rather than looking at incidence compared to mortality, they compared actual incidence to the expected number of cases we would see with thyroid cancer. And so the overall conclusion of these two studies is that we're mainly tapping into a large reservoir of patients who have asymptomatic, non-lethal disease. And that part of this is because of the increased use of high-end imaging, increased access to medical care, and doctors who are being very thorough about their evaluations. So, is it really just overdiagnosis? The previous studies seem to suggest that's the case. But about a year after the Davies paper got published, there was another study published that looked at the same database. And they broke it down, and one of the interesting findings was they looked at patients who had large thyroid nodules. So these are patients who have 4-centimeter lumps growing in their neck. These aren't the patients that you would necessarily pick up with an incidental finding on an ultrasound or an incidental finding on a CT scan. These are patients who walk into the office and they say, hey, I've got this big lump growing here in my neck. And what they found was that over the last few decades, we've seen a large increase, about close to 300% increase in patients who are presenting with these large tumors. And then just last month, there was an article published in the Journal of the American Medical Association where they looked at overall mortality rates adjusted for the incidence rate. And there does seem to be an increase in mortality from thyroid cancer. How does this affect us in Wisconsin? In 2011, if you look at the SEER database, this has changed a little bit, but I like this slide because it reminds me of the importance of thyroid cancer in our state. In 2011, Wisconsin was ranked 37th in the union for incidence of thyroid cancer, but we were ranked number 3 for thyroid cancer death. And when I saw that, it sort of struck me a little bit. Now, I say this with a little bit of a grain of salt because the ranking for the mortality rates, there's not a lot of difference between first place and second place because mortality rates are still pretty low. But nevertheless, this does make me wonder what's going on. Here's a heat map of the counties in Wisconsin with a higher incidence rates. You can see Dane County, Richland County, and Grant County have fairly high incidence rates. So these are our patients that we are seeing here in our community. And if you look at mortality, the highest mortality rate in the state is actually in Dane County. Whether that is referral bias because the more complicated cases get referred to us or for some other reason, that remains to be determined. But it certainly drives the point home that thyroid cancer is an issue in our community. So on one hand, we have the issue of overdiagnosis, and on the other hand, we have the potential for a real increase in disease. And it is my personal opinion that it's probably a little bit of both. So some thyroid cancer statistics at a glance. In 2017, we expect to see about 57,000 cases of thyroid cancer. Most of those are going to be in women. Thyroid cancer is now the 5th most common cancer in women. And we expect to see 2,000 deaths from thyroid cancer this year. And this amounts to about a mortality rate of 0.5 per 100,000. And that may not sound like a really high mortality rate unless you're the patient who's dying from thyroid cancer. So the United States Census Bureau estimates that there are 321 million people in the United States. 242 million of those are 18 or older. The American Thyroid Association tells us that anywhere between 19 to 67% of all adults have at least one thyroid nodule. So by my calculations, that means that we have anywhere between 46 and 163 million thyroid nodules out there. That's a lot of thyroid nodules. So how do we find out which ones are the ones with cancer? And more importantly, how do we find the patients that are going to die from thyroid cancer while avoiding overdiagnosis? So what tools do we have available to try to sort the important cases from the less high-risk cases? So it all starts with a good history, right? That's our most powerful tool in medicine. So anybody who has a family history of thyroid cancer in one or more relatives, anybody who's had a history of external beam radiation therapy, particularly as a child, and you'll hear some of this in some patients. I've had a couple of patients who received radiation to their chest for an enlarged thymus. This used to be done in some areas in the Midwest, particularly in Illinois, in my personal experience, though I suspect it's been done elsewhere. Patients who are younger, so if you have a patient with a thyroid nodule presenting before age 20, or who is greater than age 40, has a higher likelihood of malignancy, or patients who present with hoarseness, or difficulty swallowing, or lymphadenopathy on exam, those are higher risk patients. And last but not least, if you're a male with a thyroid nodule, that is a patient that needs to be evaluated more carefully. What other things can we do to try to sort out the less high risk from the higher risk patient? Well, we can measure the TSH. I wouldn't be a good endocrinologist if I didn't give at least one slide with a feedback loop, okay? So here we have the thyroid gland, and as we know, the thyroid gland produces T4 and T3, and whenever T4 and T3 are too low, the pituitary gland will notice that, and it'll begin to produce thyroid-stimulating hormone, and thyroid-stimulating hormone will go to the thyroid, and that leads to iodine being organified, trapped, and metabolized. You get increased production of T4 and T3, and then that exerts negative feedback on the pituitary. So I hope you really like this slide. I worked on it a lot. So let's say that you have a patient who has an autonomously functioning thyroid nodule, or what we call a hyperfunctioning or a hot nodule. So this nodule is kind of a crazy nodule, and it likes to make too much T4 and T3. So what that'll do is it'll get the T4 and T3 will exert negative feedback on the pituitary, and you get reduced concentrations of TSH. And so if you have a low TSH, you have to wonder if the patient has a hyperfunctioning thyroid nodule. And this is important because hyperfunctioning thyroid nodules are rarely, if ever, thyroid cancer. So if you have a low TSH, you evaluate that patient for hyperthyroidism. You don't go straight to biopsy. So right now we've got two tools. We've got history and we've got the TSH. Those are pretty easy things that we can do to try and sort out which patients are higher risk. What about ultrasound? Can ultrasound predict which nodules are benign and which nodules are malignant? Now, I look at thyroid ultrasounds all day. It's like what I do. And I can tell you that these three nodules, I probably can't distinguish which one is benign and which one is malignant. And maybe I think it might be fun if we have a little guess. And don't worry about guessing wrong because that's the whole point of it. But raise your hand if you think the nodule on the left is the benign nodule. Okay, there we go, Jason. Raise your hand if you think the middle one is the benign nodule. Okay. Jason, you can't raise your hand twice. And raise your hand if you think the right one is the benign nodule. Okay, great. So the left one was actually anaplastic thyroid cancer, one of the most lethal cancers known. The middle one was the benign one, and the one on the right was papillary thyroid cancer. So ultrasound is not reliable, at least not yet. The American Thyroid Association has done a lot of work to try and help refine the utility of ultrasound. There's some beautiful work being done out there trying to correlate cytology findings with ultrasound features. There's still a lot more work that needs to be done. I was pleasantly surprised to see that some of our radiologists are actually starting to use the TIRADS scoring system, which is similar to the mammography scoring system, BIRADS. And I think we'll start seeing more of that in the future. And I'm hopeful that this will help us triage those patients a little better. But we're still in the beginning stages of that. But the nice thing is that you can have some nodules, particularly ones in the lower category, which we can say, you know, the likelihood of finding cancer in this nodule is really, really low, particularly the cystic ones. We've known this for a while. Cystic nodules are never cancerous, or hardly ever. But until we figure this all out, we're still stuck with biopsy, no pun intended. So here's an image of me doing a thyroid biopsy. The person on the left is actually not really getting a biopsy. That was my medical assistant at Marshfield Clinic who volunteered for this video. Thank you, Bethany. And so here on the right, we have an image of me putting a needle in a nodule. What about patients that have multiple thyroid nodules? Conventional wisdom in the past told us that if you had many thyroid nodules, that your likelihood of having cancer was lower than if you had a single thyroid nodule. So in 2005, a radiologist by the name of Louise Davies at Mass General tried to answer this question. And what she did is she looked at malignancy rates in patients who had one thyroid nodule, and what she found was about 15% of patients with one nodule had cancer in her study, and about 15% of people with multiple nodules had cancer in her study. So there really wasn't a difference in the cancer rates between patients with a single nodule versus a multinodular goiter. Now here's the kicker. In the study, the patients with multinodular goiter, cancer was located in the largest nodule only 73% of the time. And if you had a patient with 3 nodules that were greater than a centimeter, and you only biopsied the biggest nodule, you would miss half of the cancers in that population. This is really important because we still see patients that have multiple thyroid nodules who have a biopsy done by somebody who doesn't do a lot of thyroidology. And they end up going for the dominant largest nodule. And so this is kind of a big take-home point. If you have a patient who has multiple thyroid nodules and they need a biopsy, we need to make sure that they don't just biopsy the biggest one, because there's a good chance that the cancer could be in one of the smaller nodules. Now, let's say you have a patient that has 11 nodules. How many do you actually need to biopsy? So if you've ever had a thyroid biopsy, which I've had a thyroid biopsy. I don't have a nodule. I volunteered for it. The psychiatrist said I was fine. It doesn't hurt too bad, actually. If you have multiple thyroid nodules, and if you have 11 of them, that seems like a lot. That hurts. So you want to try and rule out cancer while doing the minimal amount of pain, giving the minimal amount of pain to your patient. The answer is, if you biopsy 4 of them, you've probably ruled out thyroid cancer with reasonable certainty. And you want to triage the higher risk appearing nodules. What about follow-up? Let's say you have a patient with a thyroid nodule and you do the biopsy turns out to be benign. How do we follow up these patients? I'll give you 2 examples of patients with benign biopsies. So we have case 1. And this is an actual patient. So this is a 48-year-old woman who had a CT scan, and they noticed an incidental thyroid nodule on the scan. And this was biopsied. We did an ultrasound. We biopsied it. It turned out to be benign. And our usual practice, my usual practice when I was up north, was that if a patient had a benign biopsy, we would send them back to their primary care provider with recommendations on when to check an ultrasound. So this patient, she had her initial CT scan, and she had her biopsy, and 6 months later she had an ultrasound which the radiologist read as stable, even though the dimensions had actually grown by about 25% in one aspect and 36% in the other. And then she had another ultrasound at 12 months, and by that point they said, I think this maybe looks a little bigger. And so she had a repeat biopsy, which turned out to be malignant. And the sad story was that by now this cancer had become invasive and had eroded into the patient's trachea. So this patient now developed locally advanced disease. And fortunately, last I heard, she's still doing okay, but she's had her fair share of troubles because of this. This is a picture of her ultrasound. So the image on the top is her baseline ultrasound. And you can see the little calipers placed there. That's what her nodule looked like at baseline during the first biopsy. Here's the nodule at the bottom at 6 months. So there's a clear difference there. And I'm not blaming the radiologist that reviewed this, but we do have to make sure that we're careful about following these things. So what about case 2? So here's another case. This is a patient I recently saw here. So a 55-year-old man who had an incidental thyroid nodule felt by his primary care provider. And we biopsied it. Turned out to be benign. So he had his baseline biopsy. And his first biopsy was done by a different provider, so this was before I arrived. He had an ultrasound a year later, and that showed minimal size increase. And then had an ultrasound 2 years later, which showed the nodule had gotten a little bigger. So it was biopsied again. And then he had another ultrasound 3 years after the initial biopsy, which showed a little bit bigger nodule. And it was biopsied again and continues to be benign. So now what? What do we do with these patients? So nodule growth is this big thing. We would always tell patients that we need to watch for growth. In 2005, the Society for Radiologists in Ultrasound got together and tried to define how to follow thyroid nodules. And the panelists all recognized that benign and malignant nodules can grow. And they said, well, rapid growth is an indicator of malignancy. This was based on one study. But they couldn't agree on how much growth was sufficient to say, yep, this is a malignant nodule. So the American Thyroid Association sort of said, well, we got to give our our doctors something to go on. And so they said, well, if the nodule grows by 20% in 2 or more dimensions with a minimum increase of 2 millimeters in 2 or more dimensions, then that's significant growth. Or alternatively, we could use a volume change of 50%. Now, keep in mind, this recommendation is based on one study, one single study where they looked at about 30 people with a thyroid nodule, and they had 3 ultrasound techs measure the nodule in one right after the other. And that's the amount of variation that they found in the measurement. But it was nothing that told us that the nodules that are benign actually grow faster than the ones that, or slower than the ones that are malignant. So does rapid growth really indicate malignancy? So the title of this article tells it all. So here, this is a retrospective study of patients who had benign and malignant thyroid nodules. And they went back and compared the dimensions of the nodules and calculated growth rates. I'll focus your attention to the image, to the graph on the right. And you can see that the growth rates of benign nodules and malignant nodules really wasn't much different. So it doesn't look like the actual size change is the deciding factor in predicting which nodules are malignant. Now, what about missing malignancies? So thyroid biopsy is not perfect. It has about a 5% false negative rate. So how many missed malignancies are out there? Turns out not that many. So there are a number of studies. One of the most recent ones was published using the Mayo Clinic Olmsted County database. And they went back about 15 or 20 years and looked at patients who had benign thyroid nodules, and then they queried the charts to find out if the patients were ever diagnosed with thyroid cancer, did they die from thyroid cancer, or anything related to thyroid cancer. And they found that they really weren't missing a lot of cancers. And it turns out that there's several other studies that found similar findings. Now, the cost of doing a biopsy and doing these ultrasounds is not cheap. This is all in Medicare dollars. The cost of an ultrasound is about $109, and the cost of a biopsy is about $137. Our pathology interpretation is about $147, give or take an extra $55 if they do immediate adequacy review. So this is all in Medicare dollars. Obviously, third-party payer will probably get a different number. How many biopsies do we do at UW? Well, so here's our data. For the past 5 years, we've been steadily increasing the number of biopsies. Endocrinology has been doing about 500 biopsies per year, and our colleagues in ENT and radiology have been also growing their numbers. Most of these turn out to be benign. So we're doing a lot of biopsies. We've got a lot of patients with benign nodules that need follow-up. In fact, over the past 5 years, we've accumulated about 4,000 patients with benign thyroid nodules that are getting ultrasound after ultrasound after ultrasound with possible repeat biopsies. So again, the needle in the haystack. Which patients need to be followed more closely? So I used a conservative estimate of saying that these patients get 0.75 ultrasounds per year. In reality, they might get more. I'm estimating about 1 hour per ultrasound, $109 in Medicare monies. So how much have we spent in the last 5 years on thyroid ultrasound? Using this conservative calculation, over the past 5 years, we've spent about $1.7 million following these patients. We don't have a lot of healthcare dollars. Our resources are limited, particularly in this current political climate. So this is a potential area for improvement. How much does it cost to detect a missed malignancy? This is a really interesting study out of Philadelphia. They looked at about 5 years of data for patients with thyroid nodules. And what they did is they looked at 2,300 patients who had a thyroid biopsy. They excluded the ones with an insufficient sample. They took out the ones that were malignant or indeterminate, and they were left with about 1,600 patients with a benign biopsy. So out of those 1,600, roughly half had follow-up ultrasound images. That included 3,100 imaging studies, 2,200 ultrasound studies, 606 repeat biopsies, 168 CT scans, 78 nuclear medicine tests, 53 MRIs, and a partridge in a pear tree. What did they find? They found about 2% missed cancer rates, so pretty low rates. Most of these were small papillary thyroid cancers that were non-life-threatening. There were 2 Hürthle cell cancers, which those are actually a little bit more aggressive. But by and large, ultrasound is doing a pretty good job. Biopsy is doing a pretty good job of detecting cancer. We're not missing a lot of this. The cost to detect one cancer in this study, about $46,000 per patient. Per cancer. How are we doing at UW? So we did a review of how our biopsies have been matching with surgical findings, and our cytopathology department was very gracious to provide me with this data. So we reviewed all malignant specimens that were found at surgery, and we compared them to the findings at the time of biopsy. And if there was any discordance, they went back and actually reviewed the slides. They excluded anybody who had a micropapillary thyroid cancer or a condition called NIFT-P, or non-invasive follicular tumor with papillary features. This used to be considered cancer, but it actually isn't. So what did we find? We had 168 malignant surgeries last year. 104 of those had a biopsy done either at UW or at the Medical Foundation or the VA. And we had a 99% concordance rate. There was one biopsy that was benign and then turned out to be malignant. So overall, we're doing a pretty good job. So kudos to our pathology department. So in the past, we had told our colleagues that if you had a thyroid nodule, you had to check these ultrasounds at a year. If they grew by 20% or more, you had to consider repeat biopsy. American Thyroid Association has updated their guidelines, and I suspect they'll be doing that again in the near future. And what they said was, given the low false negative rate of ultrasound-guided biopsy and the higher yield of missed malignancies based upon sonographic pattern rather than growth, the follow-up of thyroid nodules should be determined by risk stratification based on the ultrasound pattern. Now, what does this mean? It means rather than using size, use the ultrasound appearance to help determine which patients need closer follow-up. So if you have a high suspicion appearance, you should, you should simply repeat the biopsy 1 year after their original biopsy. If you have intermediate or low suspicion, this one's still a little bit iffy. American Thyroid Association is still wishy-washy on that and saying, well, you can check an ultrasound in a year, maybe in 2 years. If it grows, you can talk about whether you should repeat a biopsy or repeat the ultrasound again. We still need to work on this group here. If you have a very low suspicion nodule, you don't need to do surveillance ultrasound. So this is something that I intend to change in my practice when I'm doing a thyroid biopsy and sending results to patients and sending results to primary care providers, saying, based on ultrasound criteria or ultrasound features, I would recommend that the patient does X, Y, or Z. So take-home points. If you have a thyroid nodule, you get a history, you check a TSH. If the TSH is low, send your patient for evaluation of hyperthyroidism. If the TSH is normal or high, then get a dedicated thyroid ultrasound, and if necessary, treat hypothyroidism. If your patient has multiple thyroid nodules, biopsy up to 4 nodules. If it's malignant, obviously treat that patient. And if it's benign, then do risk stratified follow-up. So my conclusions, the thyroid cancer epidemic is largely driven by overdiagnosis, but I think there is some real disease out there too. Ultrasound is not yet able to identify those patients who don't need a biopsy, but we're working on it. FNA, or fine needle aspiration biopsy, is highly reliable. Most benign nodules don't need intensive, indefinite surveillance. There has to be a point where we say, okay, it's all right to stop. So the game has changed a little bit. It's no longer enough to detect thyroid cancer. You have to strive to detect clinically relevant disease and only treat those patients who will likely suffer or die from their tumor. The screening process should be easy to do, cost-effective, and minimally invasive to the patient. These are my thoughts. So with that, I want to give some thanks to the people who helped provide me with the data and to my wife and kids for putting up with me while I put together this presentation. And I'll leave it open to questions.
That was terrific, Roger, and beautiful slides, I might make them. I'll ask you to call on the audience and please repeat the question.
Okay. Yes, sir. So the question is there an increased incidence of thyroid cancer in patients with Hashimoto's and Graves' disease? This has been a question that's been asked for quite some time. With Graves' disease, the concern is that if you have a thyroid-stimulating immunoglobulin that's elevated and stimulating thyroid tissue, could that stimulate the growth of malignancies? Theoretically, it would seem plausible, but in reality, we haven't seen that. As far as whether the presence of Hashimoto's increases your risk of cancer, that's also less certain. We haven't really seen that signal. What we have seen, and this was a study done by Megan Haymart, who was a fellow here, we have seen that if your TSH is actually a little bit higher, even if it's in the normal range and your TSH is a little bit higher, that is a little predictive of the presence of a malignancy. But as far as having autoimmunity or TPO antibody titers, that doesn't predict presence of cancer. Yes, sir.
Do you anticipate that the identification of various oncogenes, such as the PTEN, will modify your screening for thyroid cancer as well as other tumors?
So the question is whether the identification of certain oncogenes like PTEN could help us determine which patients need more close evaluation. That's a tough question. So there are some molecular tests available which we can obtain on biopsy tissue, which can help us stratify risk. Right now, those tests are fairly expensive to do, and we mainly use them for patients who have biopsies that have indeterminate findings. So it serves a little bit as a tiebreaker. So if you have a patient who has a biopsy and it comes back sort of indeterminate, we can't say it's benign, but we can't say it's cancer either. You can get these molecular tests done, and that can help you determine if your patient needs surgery or can safely be watched. There's a lot of concerns with those tests, especially regarding the long-term ability to rule out cancer. As far as doing genetic testing to say, okay, we're going to do a blood test that will help predict whether you're at higher risk for thyroid cancer, I don't think we're there yet. There's some interesting, so the PTEN mutation, that's the mutation seen in Cowden syndrome. If patients have Cowden syndrome, yes, they are at increased risk for thyroid cancer, and those are patients I would watch more carefully. And there was a study, Mira Milas at the Cleveland Clinic was actually trying to detect little microRNA bits in peripheral blood. I don't think that she has succeeded yet at detecting thyroid cancer. But it's a very interesting question, and I think that is a little bit where we're headed. Yes, sir. So the question is, does cumulative radiation exposure to CT scans increase the chances of developing thyroid cancer? And what about healthcare personnel who are exposed to radiation as part of their job? The literature, the last time I checked, would suggest that the radiation exposure is most critical if it occurs during childhood. Having said that, in my clinical practice, if I have a patient who works with x-rays on a routine basis and has a thyroid nodule, that is a patient that I will watch more carefully. A lot of the data regarding radiation and thyroid cancer exposure has come from what we learned after the atomic bomb detonations and after the Chernobyl accident. In fact, the images I showed here were patients who were exposed to the Chernobyl fallout. So as far as exposure at work, I would strongly recommend that people who are doing fluoroscopy cover their thyroid glands and use the thyroid guard. I don't think we know for sure yet whether this will increase your risk of cancer, but I think it might. I say that with a little bit of trepidation, but I would just say be careful. Does that answer your question? Okay. Yes, over there, sir. So the question is there consensus between the radiology community and the endocrinology community regarding the surveillance of thyroid nodules? No. I think, so I have a lot of respect for my colleagues in radiology. I think they're extremely skilled at what they do. I think that I'm going to be a little biased in my response. There's a couple of things that I think are beneficial to a patient when they get evaluated by an endocrinologist. First of all, we can take a look at the biopsy result and aid with the interpretation. So it's one thing if the radiologist does the biopsy report comes back to the primary care doctor and it says suspicious for follicular neoplasm. Some primary care doctors might struggle saying, okay, what does this mean? Neoplasm, that sounds like a tumor, right? Suspicious, that sounds bad. Well, it is and it isn't. So I think that the endocrinologist can help you, help walk your patient through that and say, okay, what does this mean? What's the probability of cancer in this type of lesion? There was the American College of Radiology had set out some recommendations a couple of years ago where they discussed whether or not we should even bother to work up thyroid nodules that were identified incidentally on CT scans, for example. And that drew a lot of controversy from the endocrinology community because the radiology community was saying if you have an incidental nodule seen on a CT, you don't need to report it. I can tell you I have one patient who had a nodule incidentally identified on a CT. It wasn't reported, and that turned out to be malignant. So I don't mean to knock on the radiologists because I have a great deal of respect for them. I think we need to find a happy medium. Their main concern is, they have limited resources, and there's a lot of patients with thyroid nodules, and they're worried about this massive influx and massive increase in the number of ultrasounds that we're doing. And their point is well taken that a lot of times we are evaluating patients that have small tumors that won't ever hurt anyone. Yes, the lady in the back. I'm so glad you asked that question. So the answer is, the question is, the U.S. Preventive Services Task Force recently recommended against screening asymptomatic individuals for thyroid cancer. And should we still recommend our medical students to be trained in physical diagnosis of thyroid nodules and thyroid examination? This isn't the first time that the U.S. Preventive Services Task Force has given a recommendation against screening asymptomatic individuals for thyroid cancer. I think the evidence for screening asymptomatic individuals would probably favor to not screen. I think that's true. The thing that's hard, though, is it's really difficult for the task force to tell physicians, don't examine someone. If I have a patient that comes in, back when I was practicing as an internist, nobody could ever tell me don't examine my patient. Or if a patient comes in and I'm just doing a general lymph node exam and feel a little bit of a goiter, I'm going to work that up. So I see their point, but I think not examining someone is a little tough pill to swallow. Do we have time for some more questions?
Yes.
There's a question in the back over there. Oh, no? And I think I saw one, the lady with the tan-colored jacket. You raised your hand a minute ago? No? You, sir. Oh, okay, you can go ahead. The question is, in patients who are immunosuppressed, particularly patients who are organ transplant recipients, do they need closer follow-up? I don't know of specific data that shows that those patients are at higher risk for having thyroid cancer compared to the general population. Obviously, a patient who's immunosuppressed will have decreased immune surveillance of potential malignancies, and I think as a group, those patients probably need to be watched a bit more carefully. Those patients they get a lot more medical care just because of the fact they have an organ transplant, and I don't know if we would find more thyroid cancers in them because they just get more medical care and a lot more stuff, imaging done. But I would say from a common sense standpoint that I would probably watch those patients a little more closely. Yes, ma'am. The question is, do I have any recommendations for screening patients that have been exposed to radiation, particularly patients who were exposed to radiation during childhood, for example, people who were treated by chiropractors in the 1950s and 60s? I think that those patients need to be watched more closely. And I think those patients should have periodic imaging of their thyroid glands. The literature is less clear on how often and for how long those patients need to be screened. My personal practice would be that I would definitely do a very careful physical examination of their thyroid gland at least once yearly, and consider checking an ultrasound every 1 to 2 years. If things look really stable, maybe check one every 5 years. This has recommendation lower than expert opinion. This is just me, what I would probably do. I don't think that we have very clear guidelines on what to do there. But I think those patients probably need to be watched a little more carefully. If the ultrasound shows a nodule and it's biopsied and found to be benign, and you biopsy it again later and it's found to be benign, the good news is that 2 fine needle aspiration biopsies with benign findings are actually really reliable. So I don't think that that particular nodule would need continued biopsies indefinitely, but you probably want to maybe keep an eye on that patient's thyroid gland for the development of new nodules after that. The question is, in that one patient that had a discordant finding at our institution, why did that patient end up having surgery? The reason for that patient having surgery is that that patient actually had a very large thyroid nodule, measuring greater than 4 centimeters. And there has been some concern regarding the accuracy of thyroid biopsy in patients with very large thyroid nodules. That's probably an entirely separate topic altogether. Some organizations, for example, University of Pittsburgh, will remove all nodules that exceed 4 centimeters in size regardless of biopsy result. So if the biopsy is benign, they still get it out. I'm not necessarily in agreement of doing that for every single patient, but there is some concern that thyroid FNA might be a little less accurate if a nodule is big.
If there are no further questions, I want to thank Dr. Kulstad for giving us an outstanding grand rounds this morning. Thanks for your time.